Thank you, Nandini. Thank you, Vijay and Dr. Vanita Kumar for inviting me and for this wonderful talk, which had already been covered in first two talks. Most of the things which I need to talk, which is second line and third line TKI resistance. Now, what are the options? I think the most important option is what we have been practicing since years is chemotherapy, what we left. But what is important in ALK, there are two things. One thing is the brain metastasis, and second thing is the lot of resistance which is happening after exposure to first generation, second generation. Now we have the best agent, which is lorlatinib, which takes care of the brain but causes side effect, which is most importantly happens in the brain. So in what I decided to do, rather than talking on those agents which are still in the labs, to talk about their efficacy and dose, I wanted to show you one of my case where this patient had been exposed to first generation, second generation, and developed resistance. So I will not go into the detail of discovery. When I was resident, then the discovery of ALK happened. When I was completing my DM, then the crizotinib, we were discussing the first data profile, and we were very amazed to look at the data and now see. After more than a decade, I'm standing here and discussing so many options. The truth fact is, most of our patients, we should be talking what our patients can afford. Most of our patients don't have access to all these drugs except those compassionate access. So then the best decision a person can take when he or she is seeing the patients in the clinic is their best clinical judgment. So I will start with the clinical history. This 44-year young, fit, non-smoker guy came to my clinic before the starts of COVID. It was February. I distinctly remember he was diagnosed in some of other hospital, came with the biopsy. I just wrote. That time we did not have too much of access to local labs of NGS. So we did the routine panel and the ALK came positive. In Mumbai happens one person goes to 3 more people. And then he jumped to another oncologist, started, and I also forgot, he also forgot, and then COVID started. So everyone forgot. So there was a lung mass with some effusion. Biopsy was ALK positive, started on crizotinib. In June 2020, so this is a retrospective thing, when he again came back to me, in June 2020, after starting the crizotinib, there was a partial response. But November, he started coughing, so there was a PET happening every 3 monthly, and there was a slight progressive disease. So the treating oncologist shifted him from crizotinib to alectinib because that was the best option probably, and that was we used to do. Crizotinib, I had done it, couple of patients, crizotinib, then triceritinib. This is 2014-15 I'm talking, and then I went to alectinib, and I had actually exposed one of my patients to lorlatinib. Wonderful drug. CNS nets disappears completely. The only problem is the patient becomes cognitive decline, so they will not remember who is treating them like that. So. But the longest PFS I have actually seen, which is translated into overall survival, is sequencing. So this particular patient initially responded 3 months for alectinib, nice response. And remember that crizotinib response was 6 months to 9 months. So somewhere around February, there was a partial response, which was 3 months after alectinib. And then again, patient started developing cough. Then he remembered me, he came back to me again. So I decided, though you have a response, looks clinically progressing, we should get a biopsy. I'm very big fan of doing repeated biopsy. That's why patients, sometimes I spend a lot of time in counseling. And from the first two talk, you remember, you must come to the conclusion that this is what is required when you are treating a patient on ALK inhibitors. So then his cough become deteriorating, and then we decided, let's do a biopsy. So before that, one thing that alectinib dose was the half of the dose. Maybe, my colleague must have thought something and he was giving the half of the dose. So I actually increased the dose and he responded. So 3 more months with a full dose of alectinib. And then again, he started developing cough. So I said, let's get a biopsy done. I'll discuss this biopsy and everything afterwards once we finished this. So this is the background we now have since 2007 when I mentioned that I was registered, and now it is 2022. We have many agents, and lorlatinib looks the best agent. This flowchart, this diagram was shown before. You look at the 3 years of progression-free survival, it is 64% with lorlatinib and 19% with crizotinib. And there are a good effective second generations TKI like alectinib, brigatinib, and entrectinib. They are also showing good PFS as compared to everything is compared to crizotinib because it has the least CNS activity. And this is the PFS graph of lorlatinib. So if somebody has lorlatinib available with free of cost, one should put the patient on lorlatinib. Only problem is CNS side effects. And there are a couple of other side effects. You have to look after what drug the patient is on. Although patients with ALK positive initial cell, all the patients do respond. I haven't seen the patient, any of ALK positive patient has not responded initially, but they do develop resistance. That is one thing, which is up to the tune of 71%. This particular mutation G120R, which is does not happen with crizotinib, but second generation TKI. If the patient is exposed to the second generation TKI, this is the most common mutation, and most of the second generation TKI shows resistance to this particular mutation. This mutation is resistant, quite resistant for second generation TKI also. Now, the second problem, as I mentioned, is the brain metastasis. To begin with, almost 30 to 40% of the patients ALK positive are going to have brain metastasis if you screen the brain. I do MRI for all the patients. If I don't get a mutation on basic tests like PCR and IST, I do the brain metastasis, brain MRI. Now I do it for everyone. But if you have brain metastasis and if your mutation is negative, please do NGS if it is not done. You will pick up some mutation. And that is all. And this is when you expose this patient to second generation or third generation, your second generation TKI, probability of developing the brain metastasis is going up to the tune of 60%. So you need to have a ideal agent which has a best CNS activity and effective against all the possible mutations. So I will not go into the details of resistant mechanism because first two speakers have so these all graphs have been discussed. So this is again, no, you see post crizotinib, you don't have a lot many mutations, but when you expose your patient to second generation, be it alectinib, brigatinib, and ceritinib and alectinib are more accessible as compared to the other two. And G1202R is the most important culprit. This graph was shown by Dr. Somani also. If you subject your patient to first generation, second generation, third generation, the accumulation of mutation also increases. As we see, the most common again here is G1202R. So now we need to have an agent which has activity across all these mutations, including the most common mutation with the best penetration in the brain. This is the most common mutation chart. Always you see. From this chart, we conclude that lorlatinib is the best agent which is effective against whatever best possible known mutations are discovered so far. So we'll come to those mutations post lorlatinib. So this G1202R is inhibited. This mutation is sensitive to lorlatinib also. Now, I'll not go into the detail of this design and mechanism of the trial. So as Dr. Nandini has showed and Dr. Somani also showed, where this drug binds to the receptor site, that decides, the mutations happening over there decides the fate of that particular drug. So this is the phase 1 trial where multiple cohorts have been concluded and lorlatinib has been placed in the first line post crizotinib chemotherapy, then lorlatinib, then second generation TKI followed by chemotherapy followed by lorlatinib, and first line, second generation TKI, then chemotherapy and then lorlatinib. So they try to look where the lorlatinib fits well. So you see lorlatinib in this phase 2 study, out of 190 plasma samples. So this is pre-treated patients. 24% had more than one detectable ALK kinase domain mutation. Total of 75 mutations were detected, and the most common is, I will not name it again. Now you must have by heart, G1202R. For those students for the exam, just remember this. I just don't look at this. I just read the report and decide what mutation and what drug to use. So those patients who did not have any mutations, still the lorlatinib works. So you see most of the mutation lorlatinib is working beyond second line. Now this graph, few years back, we used to discuss about alectinib and ceritinib. Now there is one more lorlatinib. I am not going to explain it because the last line you see, if you use lorlatinib upfront, the best PFS you get. The longest PFS is not reached yet. And I showed 3 years PFS is 64%. So the best is to use the best drug upfront. Only thing is the cost is the issue. But what I feel, sequencing is the right way. I would like to mention one of my patients which got detected with upfront brain metastasis in 2014. The only option available and accessible was crizotinib. With brain metastasis, excellent response. Maybe the radiation guys has given radiation and the already broken the blood-brain barrier. She took crizotinib almost for 3.5 years or 4 years. What I did with limited progression, that time I added chemotherapy also, but I continued the TKI. Patient again responded after 2 years, or 2 + 2 4 years. So one must remember this option also. Then in the second line, the ceritinib came. That time we used ceritinib. For some period we used alectinib, and lorlatinib was not available in India. So we got a compassionate access or that access, and she took almost for 2.5 years. The brain was completely clear of metastasis. There were miliary metastasis, but the only problem was cognitive decline, and the quality of life went down because of the CNS side effects. Maybe it is because of the radiation plus this drug. But she, with the upfront brain metastasis, she survived for 7.5 years, and we lost her in the second wave of the COVID. So it's a long journey. So with upfront brain metastasis, people are living beyond 5 years and 6 years. So it is how you put these drugs. So now, as I mentioned in my case, there is a small cohort. They tried about 67 patients. Those patients progressed beyond second line TKI, and they tried adding chemotherapy. So if you only do chemotherapy versus you continue the TKI and add the chemotherapy, you see those graphs are different. So it is suggested, though it is a very small data, you better know if you have limited progression, continue the TKI with chemotherapy. You are not going to have large randomized trials. So there will be some case reports, and this is what happens beyond lorlatinib. There is not much of data is coming. All things are case-based reports or lab-based analysis. So is lorlatinib is free from acquired resistance? So we have discussed a lot about second generation and first generation. So answer is no. Dr. Nandini mentioned about single mutations and compound mutations. So there is something called as a compound mutation. I will not go into these figures. You can go and read. I will provide the slides. These mutations, when happens, they lead to resistance to lorlatinib, but they resensitize to crizotinib and alectinib. So one must remember the repeat biopsy for those patients who are in good general condition. And nowadays we have there is a validated data that even the circulating free tumor DNA is also giving you a good number of mutations. One must try and counsel the patients to get these repeat biopsies done, get those mutations, because who knows, even crizotinib works in those patients, alectinib works in patients, those patients who are resistant to lorlatinib. So there's again one more mutation, I1171N plus 1198F mutants are more sensitive to crizotinib. So first generation TKI. And the resistance to 1171 and 1196 can be overcome by ceritinib and brigatinib. So this shows that you need to do a biopsy and see what mutations are ongoing. So this is last line. No, there is one more mutation which is pan-TKI resistant. So whatever mutations and whatever drugs available, it is not sensitive to that. So the ultimate answer is chemotherapy. Or if there is a limited progression, use radiation. Now, I call my friend, whether you are doing some research on your molecules, Vijay Patil. So he said, there is one more drug is coming up. So this name is giltertinib. Okay, no fancy name. So you see that green graph. So this is about the compound mutations. So they have tried looking at this particular compound mutation, that EML4 ALK 1171N and 1174I, and the other one is 1198 LH. So these are compound mutations which are not inhibited by any of the previous TKIs, and this giltertinib is showing reducing the number of relative cell viability. So this is again the lab-based assay. The only drug which is working over here is this new drug, giltertinib. So now this drug is not active against our famous mutation, which is G1202R. So if you detect G1202R, the effective drug is your lorlatinib. So there is one case they reported where the patient has been subjected to crizotinib, alectinib, and lorlatinib, the biopsy done, and this mutation was detected. And this drug was sensitive to brigatinib, ceritinib, and this new molecule, which is yet to be made available. So this already has spoken that this drug is not effective against G1202R. And so this is my patients whom I requested him to undergo the biopsy because patient was very young. And in this particular patient, the mutation detected was T1171M and G1269A. So this particular mutation got detected, and you see the sensitivity. So this patient was not sensitive to lorlatinib. This patient was subjected to crizotinib, 6 months progression. Patient given alectinib, which was the best available TKI at that particular time point, was resistant to alectinib. And this patient is also resistant to lorlatinib. So crizo, alectinib, and lorlatinib. And this patient, as per this report, was sensitive to brigatinib and ceritinib and entrectinib. So this is the NCCN guideline with limited CNS metastasis. You should give radiation and you should continue the TKI. And I feel the best answer to this thing is to do a biopsy and look at the mutations. So treating ALK positive lung cancer is challenging task even after we have lot many options. CNS relapse mutations causing resistance to available TKI is the reason. Best agent first versus sequencing. It is up to know the accessibility and feasibility. Lorlatinib seems best option up front, but the side effect profile. So treating lorlatinib resistance is at present is unmet need. Few TKI are coming up. Repeat biopsy should always be tried wherever feasible. Liquid biopsy and chemotherapy is always an option for those fit patients. Don't forget that you have this chemotherapy also can breach in between the two different TKI. If who knows, next best TKI post lorlatinib will be 100% effective. Thank you.